thank everyone for coming. This is our first in our community support series, and I am very excited to start it off today. I was just wondering if those of you who are just coming in, if you can, as Daniela said, turn your mics off, and if you have questions, please put them into the chat. Daniela is going to be managing the chat, and at the end, we'll have a little bit of time for Q&A. Okay. So as I said, this is our first community support series. My name is Colette Brown. I'm a psychotherapist here at A Good Place Therapy and Consulting. Today I wanted to talk about breaking mental health barriers for communities of color. As I started preparing for this, I stumbled upon something that was new and amazing. So further towards the end of the presentation, I will show you this new amazing thing that I found. I would like to just get started. So I'm going to do that. This is a much better picture of me. I don't really wear that much makeup. I actually am a career changer. I used to be a teacher in the New York City public school system. And before then, I was an academic who taught film studies, African-American studies, and so my path here has been kind of circuitous, but here I am now as a psychotherapist at A Good Place. And one of the things that I do as a psychotherapist is I work with my clients on cultural identity and societal stressors. It's one of the things that I've done a lot of academic work on, personal work on, and so I'm just excited to share this with everyone today. So as I said, today's discussion is going to be about cultural competency, racial trauma, and measuring the impact of racism for people who have been affected by it. Studies have shown that roughly 1 in 5 Americans will experience some form of mental illness in any given year. And mental illness right now is the leading cause of disability in the United States. And when I say disability, I mean the fact that work hours are lost, time with people's families are lost, livelihoods are lost. Mental illness, as we all know, is a huge crisis in the United States. 46% of Americans will meet the criteria for a diagnosable mental health condition sometime in their life. And at least half of those people will develop conditions by the time they're 14 years old. So we know that here in the United States, at least 17% of Black people and 23% of Indigenous people live with mental illness. And people of color who identify as 2 or more races are most likely to report any sort of mental illness within the past year. That is more than any other racial or ethnic group in the United States. I have so many examples of that, both in my own practice, but I think that we can probably just turn on CNN and see probably why there is so much mental distress right now. But historically, Black, Indigenous, and people of color are less likely to have access to mental health services, less likely to seek out treatment, more likely to receive low or poor quality of care, and more likely to end services early before treatment has concluded. This research has also shown that BIPOC groups are disproportionately excluded from both studies about mental health and treatment trials regarding mental health. So there is a huge disparity here that we kind of already see. And as we go, I just wanted to note a phrase that I'll be using, and an acronym.
Joe?
An acronym. Hello? Hi.
Joe,
Those of you who are... yeah, maybe Daniela, as people come in, you can mute them. There's a control for that. Okay, thank you. So I'm using the acronym BIPOC, and the reason why I'm using BIPOC is because it stands for Black, Indigenous, and People of Color. BIPOC was created to replace the term minority. I personally really find the word minority a strange term to use, since globally there are more people of color. than people who happen to be white. And I also think that by using an acronym like BIPOC, we're highlighting the differences between the lived experiences of each group of people that are kind of lumped into the larger term. And so there's no longer the kind of nondescript term of just minority. So I encourage all of you that if you've not started integrating BIPOC into your everyday language usage, I would really appreciate it if you would. Okay. So I'm sorry, my notes are on a different screen, so I'm not looking at you, and I'm really sorry about that. So the barriers that we have found that affect BIPOC people are attributed to a variety of factors. Racial and racism and discrimination, stigma against mental health, limited access to quality care, and a lack of cultural competency among care providers. Racism and discrimination, which can result in a type of fear and a mistrust of treatment among BIPOC people. For a very, very long time, people who are BIPOC have been the subject of erroneous and often, I would just say, malicious diagnosis in the mental health community. Here's an example of what I mean. Benjamin Rush, who was an original signer of the Declaration of Independence and a co-founder of the first anti-slavery society in America, is today referred to by many medical schools as the father of American psychiatry. Rush, in his description of Negroes, or Black people at the time, he described them, and I'm going to quote, Negroes suffered from an affliction known as negritude. The disorder of negritude was thought to be a mild form of leprosy in which the only cure was to become white. Ironically, Rush also observed that Africans were becoming insane in some instances soon after they enter upon the toils of perpetual slavery in the West Indies. It was perplexing to him as to why Black people would suddenly become insane as soon as they entered into the chattel slavery system. And of course, the logical emotional distress was pathologized. In 1851, prominent American physician Samuel Cartwright, also someone people learn about when they go to medical school and schools of psychology, he defined something called drapetomania, and it was, in his understanding, a treatable mental illness that caused Black slaves to flee captivity. He had another ailment called dysphagia aethiopica. And that was a mental illness that was proposed to cause laziness, rascality, and disrespect for the master's property among slaves. We even have examples today, earlier in the 20th century, where when the antipsychotic drug Haldol was introduced, ads for the drug included this wonderful caption. This was actually from a magazine of the time. So when Haldol was introduced as a psychopharmacological treatment for schizophrenia, the ads read, it read assaultive and belligerent, showing an angry Black man balling up a fist. With that sort of help from psychology and psychiatry, it is no wonder that BIPOC people have often avoided the services, mental health services, with this kind of portrayal. And this ad, by the way, dates 1967. So in addition to the other barriers, there is a barrier that we also have in mental health, the limited access to quality care and a distinct lack of cultural competency. Cultural competency is incredibly important in the treatment of people of color. because cultural competency invites an understanding of people's particular cultural constructs and I'm sorry, I'm losing the word, people's particular cultural contexts in order to provide care that accounts for, accounts for difference. One of the things that we see oftentimes in psychological services, especially in the United States, is that most psychologists and care providers are people who happen to be white. In fact, 86% of psychologists in the United States are, in fact, white. And less than 2% of American Psychological Association members are actually African American. And there's even smaller numbers for other people who are people of color and indigenous. Some research has demonstrated that provider bias and stereotyping are relevant factors when mental health services are delivered. And oftentimes, providers don't have sufficient cultural competency training. And so what we then have are providers working out of their own biases and sometimes relying upon forms of stereotyping that actually, honestly, prevent them from being able to conduct assessments that are not I'm sorry, I'm not really with my words today, that don't cause pathology. Sometimes the fear of a patient can actually cause the clinician to sometimes not really understand what some of the symptoms that they are seeing actually represent. I'm going to take a moment and drink some water. I am having a little bit of a technological problem right now. I'm going to just pause a really quick moment because I am having a bit of a frozen screen. Oh dear. Hold on. Hey, Daniela, I'm just going to ask you to do me a favor if you could. I'm sorry, participants. I'm having a bit of a frozen screen. I'm on a hotel Wi-Fi right now, and I'm just a little bit frozen. But you know what I'm going to do, are there any questions in the chat as I try to get back online?
Right now, no. Do you want me to share my screen and I can share the slides on my end? Or we could just
yeah, actually, could you do that? I'm so sorry, everyone. I'm completely frozen right now.
Yeah, let me get them open.
Okay, I'm going to stop sharing the screen, and Daniela is going to open it. I'm really sorry, everyone. Wi-Fi sometimes is not our friend.
So let me do that.
I was on these barriers can be attributed. That's slide 5.
Okay, let me.
But since we're here at a pause moment.
Sorry.
If anyone did have questions, you could put it into the chat. One of the things that, I could actually continue I'm just going to continue as if you can see the slide. And one of the last things is stigma. Different cultural perceptions about mental illness and help-seeking behaviors can sometimes cause people, especially BIPOC folk, to sometimes develop stigmas against mental health. In addition to the historical disparities of mental illness and all of the kind of strange historical instances, doctors Rush and Cartwright are examples. Many in the African American community, particularly, have attributed our identity to the ability of us to persevere and show resiliency. The belief is we survived slavery, and so we can survive anything. We can survive sadness, we can survive anxiety, we can survive depression. In this mindset, anything less would be considered some sort of spiritual or moral weakness. The problem, in fact, is that we're often failing to recognize that mental illness is much more than feeling melancholy or anxious. And mental illness is in no way a sign of weakness, nor does mental illness discriminate based on skin color. So oftentimes BIPOC people fail to recognize mental illness as an illness, as we would something like cancer, diabetes, or hypertension. And so we seek out assistance in many of our community organizations or community institutions, like, say, the church. And yes, spiritual wellness is important. But oftentimes, if someone is struggling with some debilitating mental health issue, pastoral care is not always sufficient in its techniques or in its applications. Okay. How are we doing with getting the next slide up? I'm just going to continue.
I'm just figuring it out on my end. I'm about to get it up.
Okay. Thank you, and I'm really sorry about this. My screen just totally froze. Anyway, and the last thing in this is cultural competency. Cultural competency is incredibly important, as I mentioned before. Because of the lack of diversity, especially among psychologists and clinical social workers, the mental health field has been called in order to try to bridge that gap by increasing cultural competency training and focusing on the examination of the provider's own attitudes and beliefs, and increasing a kind of cultural awareness, knowledge, and skills. But this fundamental lack of diversity has created a kind of gap in experience and a gap in understanding between providers and those who are seeking treatment. Additionally, without a kind of lived experience and relevant lived experiences, oftentimes providers who are not part of the BIPOC community might underestimate the effects that racism and discrimination play on a person's mental health. Thank you, Daniela. Okay, can we go to slide 8? Are we there? Great. Thank you so much. So the question is, what is cultural competency? We use this phrase a lot. Oftentimes I've seen it in so many environments where it's actually not particularly well spelled out. So I decided that this would be a good opportunity to spell out what we mean by cultural competency. Think of it like this. Our culture, our beliefs, our sexual identity, our gender identity, our values, our race, our ethnicity, our language, our region are all all of these things together affect how we perceive things, how we see things, how we are seen. And they also affect how we experience mental health conditions. So cultural difference, if we consider that, cultural difference can and often does influence what kind of treatments, what kind of coping methods, and what kind of supports work for us individually. So it's vitally important for culture and identity to be part of the conversation as we discuss both mental health and mental health care. The shared beliefs and values and experiences of any social or racial group can result in different worldviews, and they can have a significant impact on how someone perceives and understands symptoms. Okay, so take this as an example. A person who has experienced discrimination due to their identity might experience depression symptoms as anger rather than sadness or ennui. When a mental health professional understands that cultural differences play a vital role in the diagnosis of a condition, and when that professional incorporates cultural needs and differences into a person's care, it significantly improves outcomes. So this is why mental health care must be culturally competent. It must be tailored to the individual, to their identity, to their culture, and to their life experience. Can we go to slide 9? So cultural competency means understanding these concepts: intersectionality, power dynamics, stereotypes, biases, and microaggressions. So intersectionality, the concept of intersectionality was first proposed in 1989 by Black feminist researcher and professor Kimberly Williams Crenshaw. She used this phrase to represent the many different layers of social stratification that can combine to disadvantage people. So intersectionality, okay, thank you for coming, Nubia. Intersectionality includes factors like race, sexual orientation, social class, age, disability, gender identity. And so if we kind of expand this idea, we can include what the sociologist Patricia Hill Collins described as intersectional points. And these intersectional points are the places we experience domination through the power dynamics of oppression, privilege, or to say it really simply, white supremacy, and all of the kind of institutional and ideological practices that support white supremacy. And they're supported by things like stereotypes. They're supported by personal viewpoints called biases. And they're also supported by, oddly enough, microaggressions. I wanted to talk about microaggressions because it's another phrase we've heard a lot about lately, and I don't always know if it's well defined. But microaggressions are these kind of thinly veiled everyday instances of racism and homophobia and sexism and transphobia and on and on and on that you commonly see in the world. Sometimes a microaggression is an outward insult. Sometimes it's a kind of toss away comment or gesture. But oftentimes microaggressions are unintentional. And these interactions or behaviors communicate some sort of a bias towards a historically marginalized person. Now, the difference between microaggressions and overt discrimination, or macroaggressions, I guess, is that people who commit microaggressions might not even be aware that they're doing it. So here's an example. Commenting on how well an Asian American speaks English, which presumes that the Asian American was not born here, is an example of a microaggression. Presuming that a Black person is dangerous or violent is another example. We all know the stereotypical example, the Black man being followed around in the store, or the Black person getting on an elevator and have people move away or grab their purses or kind of body check their wallets. Now, it's interesting, if you actually have had that experience, I often encourage people who do this, and people who happen to be white do it, and sometimes BIPOC people do these things, as they're in the process, to catch themselves and have a little moment of mindfulness and say, why did I just do that? And in that moment, you can kind of examine what was the impetus for doing that, a little technique out of mindfulness. But in summary, cultural competency is a core component of what we call especially in clinical social work, the whole person approach to behavioral health care. And that means that providers take a number of factors into consideration when treating someone beyond just race and diagnosis. One step that mental health care providers have taken is to implement some sort of training that encourages deeper cultural competency, which then provides the clinician with an understanding of the importance of culture and the importance of cultural identity and the different ways intersectionality affects the client. And in that way, we can provide the best level of care possible. So if we can progress to the next slide, to the racial trauma slide. Yeah, yeah. Racial trauma. So racial trauma is important, and I wanted to spend a little bit of time in the second half of this presentation focusing on assessment and treatment. Now, I know some of you out there are actual clients of A Good Place, and I know that some of you are also clinicians. And I think that the information helps both people who are receiving services and also service providers. I often think that an informed person in healthcare is a better person in healthcare. And so I wanted to kind of present something that I stumbled upon as I was doing research for this presentation. The traumatizing nature of various forms of racism is called racial trauma or race-based traumatic stress. And this is the cumulative effect of racism on a person's mental health. And racial trauma has been linked to anxiety, depression, despair, and suicidal ideation, as well as physical health issues. So we use a thing called the Diagnostic and Statistical Manual of Mental Disorders, or the DSM. That gives us a set of symptoms that we then use to create a diagnosis of a person's particular mental health distress. And it also helps us to then frame various forms of treatment for that person. So within the DSM, the framework for post-traumatic stress disorder, or PTSD, helps us to understand how to help people who've experienced some sort of life-threatening traumatic event. However, it doesn't really outline specifically trauma based on race. So I would like to kind of introduce that to the diagnosis, or the way we look at post-traumatic stress. Because post-traumatic stress caused by racism or racial trauma is likely to be under-recognized due to a lack of awareness among clinicians. And sometimes clinicians, both BIPOC clinicians and clinicians who happen to be white, sometimes there is a discomfort around discussing race in the therapeutic setting. And I think that it is mainly due to the fact that there hasn't really been any good validated measures for its assessment. Oftentimes, having a clear treatment criteria helps clinicians. So luckily, this year, August 2020, a group out of the University of Connecticut called the University of Connecticut Racial and Ethnic Stress and Trauma Committee created the UConn Racial Ethnic Stress and Trauma Survey, or UNRESTS as it's known. And it's a clinician-administered interview. So the UNREST is helpful to clinicians because it helps as an aid to uncovering racial trauma. And it can be used to develop a culturally informed case conceptualization. And it takes into account the experience of racism in the diagnosis of PTSD whenever it's warranted. So I have on the next slide a couple of excerpts from the actual assessment tool. And I just wanted to introduce it to people so that we can kind of see what it does for us. So measuring the impact of racism, the tool allows us to talk to specific life experiences of the client and allows them to kind of I guess, provide a framework or even an outline or a history of that person's interaction with racism and the different forms of racism. So I've included here a couple of pages. The first page, if you notice that there is a specific guide for the interviewer on one side, and then specific interviewer questions on the other. So in here, it encourages the interviewer first to use proper terminology. It prompts the interviewer to note the difference between race, which is the group society puts a person in based upon their appearance, phenotype, and ethnicity, which is a person's culture based on their heritage. And for some people, their race and their ethnicity might be different. And for some people, their race and their ethnicity is the same. Now, why is this pointed out? Well, it's obviously pointed out because oftentimes the terminology is used interchangeably. But it also opens up the possibility to understand some of the more intricate ideas behind race and ethnicity. For instance, the Hispanic and Latinx communities, which sometimes have a race and sometimes have an ethnicity and sometimes have both at the same time. It allows us to kind of widen our understanding of a person's racial identity, ethnic identity, and how those two things intersect. The Yukon, the unrest measure also gives us a wonderful script, which is kind of useful. It tells us, as we do these interviews, the following. Sometimes people have had very bad experiences that cause feelings of stress or even trauma. Some people have several different experiences over a lifetime that are manageable individually, but together they lead to feelings of stress or trauma. I want to talk to you about some of your experiences of stress or trauma as it relates to your race or ethnicity. It then prompts the question, how would you describe your race or ethnicity? I'd like us to take a moment to ponder that question. Asking a person to self-identify in many ways undermines very much the kind of kernel of racism, which is very much about classification and positing a person into a box. Asking the interviewee to self-identify both allows them to maybe even open up a discussion about some of their complex relationships to their racial or ethnic identity. It also includes the fact that phenotype is varied and diverse. And there are many people who have a racial and ethnic identity that may not be typically understood phenotypically. I wanted to offer up an example today. Yesterday I was meeting with a client, I'm going to call her Peggy. And Peggy explained that she had experienced a microaggression on the part of her brother-in-law. Peggy is a petite, biracial woman who, in her words, passes as white. When people meet her, she offers up her racial identity and her ethnic identity as a African-American and Italian and Greek-American woman. However, phenotypically, people often assume that she is a person who happens to be white. And so she often is made to witness these kind of microaggressive racist comments, often couched in jokes. And she is someone who has been told, both by BIPOC people and people who happen to be white, well, you're not really a person of color. You don't look it. Well, for her, the experience of her racial and ethnic identity has always been something that she has felt very strongly attached to. And so when she is victim of microaggressions, it touches her on many, many, many levels. Both levels of feeling fully accepted in her racial and ethnic identity, both with the idea that she is often essentialized, made into something that she is not. And also, she is someone who is often told by people what her racial and ethnic identity should be based upon their perception of her. Imagine the stress of every day, the gaslighting of every day being told, you are not as you feel you are not as you see yourself. I offer that up because sometimes when we think about racism, we often think about what the next section here, section C of the questionnaire, talks about: direct, overt racism. And these are the forms of racism that people experience just going about their day. We think about that poor birder in Central Park who was assaulted by that young woman. We think about maybe our own experiences going about our everyday lives and encountering maybe a racial slur, maybe a racist joke. The questionnaire asks people to share a time when they were impacted by racism. The question is quite open. It can include something that someone has either said or did to you. And the questionnaire is particularly interested in any experiences where a person felt concerned for their personal safety and the event was very upsetting. Imagine that as an everyday phenomena. Concern for your personal safety because of your race, and also having the emotional upset of the particular incident. This questionnaire invites people to bring that into their consideration of the stress and anxiety and trauma that they're experiencing. The questionnaire also asks questions that are of particular interest to clinicians, mainly, how old were you when this happened? What led you to believe this event happened due to your race? How upset were you by this experience? And if the distress was present, are you still upset by it? And did you fear for your life, health, or safety? And if yes, they ask you to explain how you were experiencing that fear. Can we go to the next slide? Thank you. The next sections that I highlight on the questionnaire talk about experiences of vicarious racism. And that is pretty much what the entire world has experienced ever since forever. But we particularly experienced it during COVID lockdown with the death of George Floyd, which was then a 24/7 news feed for all the world to see over and over and over again. I can't imagine how many of you were able to avoid it. I think probably zero. But some of us actually did bear witness to the full 8+ minutes of that horror show. That sort of vicarious racism affected, I think, every single person. But imagine if you're a person of color and you find yourself actually physically identifying with the incident. The questionnaire asks the client, can you share a time when you were impacted by racism as a result of something you learned about, for example, on the news or in your community, that involves someone you did not know personally? Much of PTSD actually requires a personalized experience of the trauma, but this scale recognizes vicarious trauma. At the end of the questionnaire, it then helps the clinician establish the actual diagnosis for post-traumatic stress disorder by means of a scaled and graded assessment at the end. Okay, can we go to the next slide? So the question is, what can we do for clients experiencing racial trauma? How can we help a client who is experiencing racial trauma to heal? Well, one of the ways are using assessments like the unrest and various others that address racism directly, inviting the subject into the therapy room, and also giving the clinician a scaffold or a step-by-step guide to discuss racial trauma. I actually think that sometimes having instructions helps. And sometimes having a guide like the unrest allows that uncomfortable conversation to come in and takes a little bit of the stress, honestly, off of the clinician and off of the client for having to find a way to structure that interview or structure that experience. We all know that racism continues today. It's an incredibly destructive force within American society, within global society. And honestly, I would say that I consider racism an affront to the ideals of modern America, whatever those would be. But I happen to be one of those nuts who walks around with a constitution in my bag. And I do think that there is something to be said for the hope of this country as an ongoing experiment that's always needing further adaptation, tweaks, and improvement. In that spirit, when we think about individual experiences, identities, and lives that have been marked by discrimination, by prejudice, by violence, when we put those experiences center in our practice as mental health care clinicians, it helps our clients because we join in bearing the burden of both identifying the perpetuation of racism within our society, and also we take on the responsibility to treat the psychological distress and the mental wounds that result from it. Using guides like the Unrest, taking trainings to bolster our cultural competency, these types of moves, I posit that they enhance our understanding of individual reactions to racially traumatic events. And it actually can, I think, help create quality care that we all can only be proud of, but we can seek out. So with that in mind, I would very much like to open up for questions. Do we have questions?
Let's see. I'm just looking at the chat. We don't have any questions yet. We actually have one from Kara that just came in. Kara is actually another therapist at A Good Place Therapy, and she is asking, what is the best way to begin engaging a guarded or reticent client in a discussion about racial trauma? She says she wants to be respectful if they are uncomfortable going there, but also does not want to perpetuate the trauma by sidestepping it.
Great question. So as we do with anything, as clinicians, sometimes there are boundaries that our clients have established with us. But one of the things that we can do is to enter it with the spirit of transparency. If you are a clinician who happens to be white and you're working with someone who has experienced some form of racial trauma, you can say to them, this is maybe going to be uncomfortable, and I'm going to work very hard to be open to those moments of discomfort. But part of the discomfort is starting the conversation. And if you believe that your client may have experienced some form of racial trauma, opening yourself up to the discussion and being very transparent with the client about both the potential difficulty of the conversation and establishing some sort of procedure by which the client can halt the discussion if necessary, or even pause the discussion in order to, address maybe tearfulness or overwhelm. How do you begin to engage? As we do everything else, we have tough discussions all the time with our clients. We discuss abuse. We discuss psychic trauma. We do this. We have to discuss race in the same spirit. If we have hard conversations, we should be able to have hard conversations. Are there any books I would recommend to help a Caucasian client better understand common cultural touch points? I do have a book that I can recommend. I actually was going to ask that we put this into, attach this alongside, it's called The Definitive Guide to Mental Health for Black People. and it is by Dr. You know what? I'm going to actually call it up and I'm just going to show it to you. Are there any platform efforts you're unaware of the works to get the unrest tool more integrated, accessible, and trained? So the university, I'm going to first address the question that is here. Is there a platform or efforts that you're aware of that works to get the unrest tool more integrated into practice platforms that's accessible and trained? The University of Connecticut group has actually offered up the unrest tool as freeware. The paper where they discuss 3 case studies where they use the unrest tool and the actual tool themselves are available. I am going to, when we repost this in our blog space, there'll be a reference page where I'll have all of the links to both the unrest tool and the paper that accompanies it, which describes its use in a clinical setting. But the researchers very much wanted this to be and wanted it to be freeware. So it is just open to anyone who wants to use it. As of now, I do not know of any specific trainings. It's very much like other types of clinical assessment tools we use, like the GAR, which we use to assess anxiety, or any other types of assessments like that. So there's not a specific platform for it. It's very much it's very much written in a way that a person can honestly pick up the assessment and read it directly and use. They actually wanted it to address the earlier question of how do you begin to have the hard conversation, and the tool is designed to open up those hard conversations. Let's see. Is the unrest tool being utilized? Is there any research being done? I know that as an RN, I've witnessed so much racism on many levels within healthcare delivery. I hope that this training can be made available to nurses, MDs, law enforcement, and EMTs. Yes, in the paper where the University of Connecticut Department of Psychology introduced it. It accompanies a study that they did where they actually used the tool specifically over the course of the last year. So I think they started using it in January of 2019. And then they published their paper showing it. And they have it included with 3 specific case studies. And the 3 case studies are scaffolded. So there's someone who experienced overt racism in the form of violence, someone who experienced vicarious racism, and then someone who experienced what we think of as microaggressions, and how that tool was helpful in the treatment of those different cases. The text I was thinking of is called The Unapologetic Guide. Guide to Black Mental Health. And it is written by Rita Walker, Dr. Rita Walker. And in it, she talks a great deal about ways to have, it's actually written for clients. It's written for, specifically for lay folk. And it's how to navigate an unequal mental health care system. And it offers tools for emotional wellness. And it also has resources to help BIPOC communities receive quality care. I love Dr. Walker's work. I hope that she goes into many, many editions. It was just published last May in 2020, so it's a fairly new piece. And in reading it, she actually, that book had a great deal to do with the way this presentation was scaffolded. She has a large section where she discusses the 4 elements that get in the way of quality healthcare for BIPOC communities, and she structures the book up against those. But in answer to the previous question about is the tool being utilized? Yes, I'm utilizing it personally in my own practice. and it has become very helpful in creating treatment forms for people who have experienced racial trauma. I have received some training in trauma-informed therapies and treatments, and I've been able to use the unrest to tweak and alter those types of interventions that I use. Any other questions? Well, I wanted to thank. I just put Dr. Walker's book in the chat, so if anyone wants to pick up the title, there it is. I thank you all for coming today. I'm very apologetic for the technical difficulties. I'm actually in a hotel room right now, and the Wi-Fi is a little dodgy. So my screen kept freezing, and I couldn't quite get to my notes at the beginning. But thank you, Daniela, for picking up the slack with that. We have many, many more of these planned. Daniela, do you want to tell the participants the next event we have planned in this series?
Yes, thank you, Colette, and thank you for hosting this amazing session. I hope everyone enjoyed it, and if you have any other questions later on, you can always email Colette directly. Her email's here on the screen, and you can always reach out to me through email. And our next session for the month of March is focused on handling the mental health when it comes to the fourth trimester. And our A Good Place therapist, Amy Warren, she specializes in postpartum depression and the well-being of parenthood and motherhood and infertility and these types of issues that people have potentially getting pregnant, staying pregnant, delivering postpartum. And so the next session next month will be on the fourth trimester. So it's actually not a few months, it's those several months after having a child, whether that be through adoption, through, a vaginal birth, a C-section, any kind of thing that any kind of way and method that you have a child. And we will be promoting that soon. So I hope that anyone who is interested in that will sign up, and you can always reach out with any questions again. And thank you everyone for joining us today and taking the time. And thank you, Colette, for spending your time putting so much effort into this.
It was absolutely my pleasure. And I wanted to just stress that this was the first one. And I thank you all for your support and your attendance. I'm going to be giving Daniela a list of all of the various sources that I pulled together to make this presentation. And since it's open source, I can even talk to Daniela possibly about putting a copy of the Unrest on our blog space. People can actually pull it straight off of our website. It is offered up freely and in the spirit of generosity of the researchers. So please look to our blog space for that. And I thank you all for coming. Take care and be well and be kind to yourselves.